It's my pleasure to now introduce Dr. Armin Rashidi, who is an oncologist at the Fred Hutchinson Cancer Center, where he cares for patients who receive stem cell transplants or cellular therapy for blood cancers. Dr. Rashidi studies the impact of the microbiome on patient outcomes after these intensive therapies for blood cancers, with the goal of improving patient outcomes while undergoing treatment. Thank you so much for joining us today, Dr. Rashidi.
Hi, everyone. Thanks so much for the invitation. I'm excited to present this work to you today. As mentioned, I'm a transplant physician, stem cell transplant physician at Fred Hutch. And the focus of my work, my research is on the microbiome, its changes after and before stem cell transplant, and how it might mediate outcomes and complications of this difficult treatment procedure, and how we can use FMT and other microbiome therapeutics to mitigate these adverse outcomes. So when I was in University of Minnesota, before joining Fred Hutch, we did the first randomized placebo-controlled trial of FMT using Alex Koritz's product in patients with blood cancer who underwent allogeneic hematopoietic cell transplant. And I will briefly review the main results of that trial, and then follow up with what we are doing now as of a few months ago at Fred Hutch. So these patients with blood cancer come to our practice every day, and we've identified an allogeneic hematopoietic stem cell donor for them who will donate stem cell products. And we put the patient under some form of conditioning regimen, which is chemotherapy plus or minus total body radiation. Sometimes this is a mild reduced intensity regimen, which can be done partially or purely outpatient. And sometimes it's more intensive. It has to be inpatient, sometimes leading to several weeks of hospitalization and a lot of complications, such as mucosal damage, bloodstream and other types of infection, dietary, nutritional compromise, fatigue, muscle wasting, and a unique complication of this transplant, which is called graft versus host disease, or GVHD. What is GVHD? Because of the HLA disparity and genetic disparity between the donor and the host, there is always a chance, and it seems to be about 50% chance, that the stem cells, and therefore immune cells arising from the donor, attack the healthy epithelial cells of the host. And if this happens, it can cause a rash, nausea, vomiting, diarrhea, liver damage, liver failure, and death. And this is called graft versus host disease. It's a common complication. Despite all the prevention, GVHD prophylaxis as standard of care we use in all patients, it still develops in about 50 to 75% of patients. At the same time as GVHD prophylaxis, we give patients antibiotics to prevent infection. And unfortunately, these patients, despite all of these prevention and advances in supportive care and clinical care, nearly all of them develop one of these four complications. Either they get infection, or they get GVHD, they might die, unfortunately, or they experience relapse of their underlying blood cancer. So we do all of this to see only about 10 to 20% of patients that don't get any of these bad complications. One problem that I think is the root cause of our lack of sufficient advance in preventing all of these adverse outcomes at the same time is the fact that many of the causes for these adverse outcomes are different. So the same cause would have different directions of causality with these outcomes. What that means is, for example, if we prevent GVHD very effectively with the use of immunosuppression, it actually increases the risk of relapse. If we try to give a lot of antibiotics to prevent infection, we disrupt the microbiome and we can increase the risk of graft versus host. So what happens to be the case as the evidence continues to accumulate is that microbiome seems to be so far, the unique underlying correlates or perhaps cause of all of these outcomes. So it's the same direction. Microbiome damage can increase the risk of relapse, can increase the risk of infection, can increase the risk of GVHD, can increase the risk of death. Therefore, we hypothesize that if we can target this common player in these adverse outcomes, we might be able to mitigate those. So there is significant amount of data now, including some of our own work that shows intestinal dysbiosis, disruptions in these gut microbes can lead to infections, acute GVHD, and death. Therefore, we use prophylactic FMT shortly after transplant to see if by fixing the microbiome, we can prevent these poor outcomes. So this is the product that we used in both trials. In the University of Minnesota trial, we used 5 oral capsules per dose at once. These are oral capsules, encapsulated bacteria. You can see some details here. And in C. diff patients, we had about 50 to 60% chance of engraftment. There was zero data in our patient population. So we used product from 4 donors. Each patient received product from a single donor. So we didn't pool the product. And what we designed the study as was a randomized double-blind placebo-controlled phase 2 trial. 100 patients, vast majority had stem cell, were undergoing allogeneic stem cell transplant. A minority were AML, acute myeloid leukemia patients in the non-transplant setting. So once they recovered their neutrophils and we thought intervention is safe, that's about 3 weeks after stem cell transplant approximately. They were randomized 2-to-1 between FMT versus placebo. Physicians and patients, neither side knew what was in the capsules, hence the double-blind term here. And the primary endpoint was infection, because at the time, there were a lot of concerns that FMT might actually lead to transmission of bacteria within the product to the patient, and these patients are severely immunocompromised, could we potentially cause harm. So we actually thought by fixing the microbiome, we not only this is a safe measure, but we might also be able to decrease the risk of infection. So quite a radical idea at the time. And what we showed was a lot of patients consented, few refusals, which was very encouraging. We managed to complete our target accrual in the transplant cohort. There was no increase in infections, as you can see in the plot here. So each curve shows the cumulative incidence of infection with FMT being in this orange-brown curve and placebo in the dark blue curve. In fact, if anything, the risk of infection was a little bit lower after FMT, but either this was not statistically significant, but it's possible that we needed a lot larger sample size to demonstrate a significant positive effect in this regard. Nonetheless, FMT had a huge restorative effect on the microbiome by improving its diversity, by decolonizing the stool from a number of pathogens that are important in the setting of stem cell transplant, and by restoring a number of commensal flora. So I won't spend too much time on this, except by saying that in these 5 plots, you can see at baseline, before we had done anything, before transplant, before chemotherapy, before anything, the FMT and placebo samples. So again, we haven't done anything, but these patients have already been assigned to one of the 2 arms. They are the same. In terms of composition of the microbiome, they're the same. That's how they're supposed to be, because randomization is supposed to randomize the composition of microbiome just like any other clinical factor. But they are highly different from donors, which are shown in red. Again, these are patients. They've been exposed to a lot of sources of microbiome injury. Donors haven't. Before those one, still we haven't done anything. That's why the superimposition does not change. And again, everyone is different from the donors. All patients are different from donors. But as soon as we intervene, we give FMT versus placebo, you can see that FMT, patients on the FMT arm, their microbiome is now separating from the placebo arm, and it's actually moving towards the donor, which means the composition of the microbiome is shifting towards a healthier commensal composition. And 28 days after, the separation is even more apparent, again towards the donor. And very interestingly, 9 months after this, the separation is even more. So the beneficial effect of FMT on the microbiome was not only profound, but also durable. 9 months after intervention, very unique finding. And Enterococcus happens to be, one of the genera in transplant patients where certain species of it have been associated with acute GVHD and poor outcomes after transplant. Very nice reduction of this genus after FMT, but not after placebo. As you can see here, the brown or orange, in donors, there is very little, if any. At baseline, there is some in both groups. Within the next 3-4 weeks, while patients are undergoing their chemotherapy, they're exposed to antibiotics. Enterococcus grows in both groups, but after intervention, it drops to almost donor level, very low level after FMT, but it keeps going up after placebo and only partially recovers once antibiotics are discontinued and patients are doing clinically better. And finally, what you can see here is the diversity as measured by Shannon index. Again, highest in donors, of course, but it goes down after placebo, or doesn't improve as much, I should say, doesn't improve as much after placebo, but improves a lot after FMT and starts to approach healthy donor levels. So engraftment of the donor microbiome was about 30%, 35, 40%, as you can see in this pre-FMT, day 10, post-FMT, day 28, post-FMT. These are taxa that are derived from the donor product. There was no hint of it in patients' own pre-intervention, pre-FMT microbiome. So they came from the donor, and it only grew with time. So something around 45% of the taxa after 28 days after FMT belong to the donor, reflecting the fact that the donor microbiome, in fact, displaced or replaced the patient's microbiome. If this engraftment rate was more than median among all samples, which means you calculate all engraftment rates, find the midpoint. If the engraftment was more than that midpoint or less than that midpoint, there was a huge effect on the risk of acute GVHD with poor engraftment, less than median. The risk of graft versus host disease, you can see how higher it is compared to if engraftment was better than median. This suggested that better engraftment of donor microbiome may lead to less acute GVHD. So in summary, in this first trial, which is now published in 4 papers, we showed that FMT was safe in arguably the most immunocompromised fragile patient population in medicine. Key to success was rigorous screening of the donors and their stools. FMT modulated the microbiome with effects that in other studies and our own studies in the past have been shown to be associated with better outcomes. Particularly better engraftment seems to protect against acute GVHD. We now have some findings, now just published 2 weeks ago, that precision engineering, laboratory manipulation of the FMT product may actually improve its efficacy for acute GVHD. And so I think chapter 1 is closed, that FMT, even in this most severely immunocompromised patients, is safe, it's feasible, patients consent to it, patients like this idea, we like it too, and it's highly effective on the microbiome. The next chapter, which is the second trial, which we are now, we're several months through, is that by increasing the dose of FMT and by selecting the best stool donor, we might be able to better prevent graft versus host disease. And so this makes the basis of the next trial, which is ongoing at Fred Hutch, another phase 2 randomized double-blind placebo-controlled trial using the same product, but the dose is about 5 times higher. And we are again using it in the prophylactic setting, this time to prevent severe, potentially fatal acute GVHD, and it's funded by Leukemia and Lymphoma Society Clinical Trials Award. So in the run-in phase, what we do is we use three of Alex Goritz's donors and give product from each donor to 4 consecutive patients. Same mechanism, same everything, except instead of 5 capsules at once, is 3 capsules per day times 7 days. So 21 capsules instead of 5 capsules, over 4 times larger dose, but it's more sustained. So our hope is to improve engraftment by this. And at the end of this trial, this run-in phase, which has now been completed, we are trying to find the donor that yields the best engraftment rate to then use that donor as the sole source of FMT product in the randomized phase, where we will randomize 126 patients using the same design, same everything, this time between FMT and placebo, same dose, same schedule, same timing as the last trial after neutrophil recovery, immune system recovery, this time to see if we can prevent a fatal, potentially fatal outcome of transplant, which is grade 3 to 4 acute GVHD. It opened to the run-in phase opened to enrollment in November last year. It completed completed enrollment just over a month ago. We are almost finished with the analysis, and the next phase will open in just about a month, I hope. These are the individuals who helped with the conduct of the previous trial, and some of them are still helping with the current trial. And this was a big teamwork with really minimal resources. And I will pause here on this slide to show the financial challenges, which were really the biggest challenge for us, the thing that was relatively out of our control. Nonetheless, we managed to do it. And I open it to any questions. Thank you.
Thank you so much, Dr. Rashidi. It is incredible to see the progress being made in such a vulnerable patient population. We're really excited to hear the results of the new trial as well, and have just a couple questions today as well. First question is, will the timing in the new trial be similar to the previous in terms of FMT administration after transplant and antibiotics, or will there be any changes in that?
Almost entirely the same, with one exception. In the previous trial, we gave the product as soon as feasible after neutrophils rose to 1,000. This was because at the University of Minnesota, we stopped prophylactic antibiotics at that threshold of neutrophils. At Fred Hutch, we stopped those antibiotics at 500. So this is the only difference. We give it as soon as patients are ready after neutrophils reach 500. I don't think the threshold matters that much, but we've never looked at it rigorously.
Thank you. Thank you so much. Another question is, with the first trial, did you notice a difference or any trends in engraftment and patient response between the 4 donors in the initial trial that are helping identify the super donor in the secondary trial?
So in the first trial, there was a hint that donors were a little bit different, but the amount of heterogeneity we had in patient characteristics, their conditioning regimen, antibiotic exposures, underlying disease, age, sex, all of that was so much that we couldn't confidently attribute different rates of engraftment just to which donor we used. In the new trial, again, learning from what we got in the previous trial, we're not allowing any conditioning, any GVHD prophylaxis. We are actually allowing only a few categories of these, and we are stratifying the randomization to properly balance the 2 arms for all of these variables. And I think this is how we can now more confidently say which one of the 3 donors is going to be the super donor.
Well, we're excited to hear more about the trial, and you said that is starting this June upcoming here. And so if patients are interested in learning more, is clinicaltrials.gov the best place for them to go to learn more about that trial?
I think so. Yeah, that's a pretty good resource. Nothing has changed really since the design and initial opening of the trial, so it should be up to date and accurate. We plan to publish the results of the run-in phase in a paper soon in the next few months, and that will be another resource. And of course, if there are questions, my information, patients and families and others can find on Google and just contact me.
Thank you so much. We are so amazed by the work that's being done and so grateful for your investment in helping patients find more success after already undergoing so much for treatment of these health conditions. And so thank you so much for your time and for being here today and for sharing the incredible work that you're doing.
Thanks so much.